his busy schedule as the state president. Welcome you, sir. Next, I would like to welcome Shimmy, sir, who has started this series of talks for the benefit of house surgeons in their day-to-day practice. Welcome you, Shimmy, sir. Next, I would like to welcome our vibrant secretary, Dr. Gopi Mohan, our treasurer, Dr. Binukutan, our joint secretary, Dr. Ranjit, for their constant support in arranging this HIP series for house surgeons. Last but not the least, I would like to welcome my own convener, Dr. Nisha Krishnan, who had been busy arranging the house surgeons throughout the state for this program. Welcome, Dr. Nisha. Now, I would like to welcome all my dear house surgeons who are present here on this platform, and I wish this CME series a very good success and a great learning experience. Thank you.
Thank you, Dr. Johnny Sebastian, sir. Now I will invite Dr. Riaz, sir, President IAP Kerala, for the inaugural address.
Thank you, Dr. Sala. So, today is a very auspicious day for IAP Kerala Team 2025 because following the legacy of IAP in academics, we are continuing a program which was started by Dr. Shimmy as president last year, which has been established and which has been uploaded as a very popular program among house surgeons and general practitioners in the state. So when we are when we were in Trivandrum Medical College, after completing MBBS, when we go to the wards, then was the real test of our clinical knowledge, because most of the time at that time there were no PGs even around, and we were asked to take care of sick patients in the medicine ward and all. So at that time we had some books, some handouts or tips which we got from our seniors and our teachers. So now in the digital world, nobody is ready to look at the books. So IAP Kerala is actually having this series and we are archiving it. Dr. Ranjit has already linked it to the YouTube, and our house is full now. 100 participants are already there. So those who could not join, if any of your friends are telling, you can actually ask them to join the YouTube link. And this day I should actually congratulate a few people. One is, of course, Dr. Shimmy for bringing out this idea and making it a part of his action plan, which I am just copying and continuing. Then Dr. Joni and Dr. Gopi Mohan, our current secretary, who were passionately doing this for the full year last in 2024. And they were actually doing a lot in choosing the topic, choosing the speaker, and making the news available to all the house surgeons all over the state. And Dr. Ranjit, we cannot thank him enough for being a constant presence in our webinars for troubleshooting, because after being in the air, it is very difficult to control everything. So Ranjit is there. And this year, actually, Dr. Nisha and Dr. Johnny again is leading the show. And I offer them all the best. And I also acknowledge the presence of all the seniors and IAP leaders here. And I offer a grand welcome from IAP Kerala to all our kids, the house surgeons, for whom we are planning this program. And I also appeal to the house surgeons to give your suggestions to your coordinators. Every college has a coordinator, and help us to make the program better. Thank you. All the best. We'll continue with the program.
Thank you, Riyaz sir. Now I invite Dr. Shimi Paulo sir for the felicitation. Past President IAP Kerala for the felicitation.
Thank you, Dr. Sala. Dr. Johnny, the chairman of the program, and Nisha, the convener, our state president, Dr. Riaz Binukutan, Ranjit, and of course, the speaker of the day, Dr. Sheeja. I should actually really congratulate Dr. Johnny and Gobi Mohan actually for having taken us through 2024 with this program. And now in 2025, there's just a change of baton, Dr. Nisha taking charge. And I think so with Dr. Nisha being an academician as such, we might be able to even support the program even better with more of topics. Like how Dr. Riaz said, definitely this was useful last year for the house surgeons when it comes to their OP practice as such. So, and getting speakers like Dr. Sheeja and many others were the crowd puller also last year for us. So only thing is the topic that we select, and that I think so the ideal topic would be something that they face in their day-to-day practice as a take it as a GP practitioner. So I think so we should think in that level and start selecting a topic. And of course, I think so the whole year we have enough and more topics to train them on, because I think so every year the interns will be, or the house surgeons will be changing over. And of course, every year new tips are coming in. So I wish the program all the best under the leadership of Dr. Gobi or Dr. Johnny and Dr. Nisha. And definitely, I hope that it will be a learning program and academic feast for the house surgeons as well as whoever is joining in. I mean, not only the house surgeons, even it is useful for a practicing pediatrician who's not in touch with these books as such. So wish the program all the best. Jai AP Jai. Thank you.
Thank you, Shimi sir, for the nice words. Now I invite Dr. Gobi Mohan sir, Secretary IAP Kerala, for a few words. Gobi Mohan sir, are you there?
I think Dr. Gopi is not there.
So is it okay for Dr. Binukutan sir for a few words now?
Oh, thank you, Dr. Stella and Team Tips. Actually, for this program, we have got the best topic and the best speaker for the inaugural program. And I wish all the success for this program. And I hope that all the house surgeons and residents will learn from this program. Thank you.
Thank you, Binukutan sir. Now I invite Dr. Ranjit, Joint Secretary IAP Kerala, for the next felicitation.
Respected State President Shimi sir, IPP, Respected State President Riyaz sir, IPP Shimi sir, and on this occasion, I would like to congratulate Gobi sir and Johnny Sebastian sir for successful conduction of TIPS program the last year. And this year, under the leadership of Johnny sir and Dr. Nisha, they will continue the glory. And like a superstar movie, in the first day, the hall is full. And like our Sheeja madam is a speaker, our webinar is also full. So best wishes with the program, and wish you all a happy learning experience.
Thank you, Dr. Ranjit. Is Gopi Mohan sir present now? He still hasn't joined.
Okay, I think Gopi will address the next meeting. We can continue with that.
Okay, okay. So now I invite Dr. Nisha, convener for tips for the vote of thanks.
Good evening, everyone. So it's my privilege to extend a heartfelt vote of thanks at the conclusion of this inaugural session. So at first and foremost, I should thank Team IAP Kerala, led by President Dr. Riyaz sir, Secretary Dr. Gobi Mohan, Joint Secretary Dr. Ranjit, Treasurer Dr. Binukutan, for giving us this opportunity. And I thank my chairperson, Dr. Johnny Sebastian sir, for giving all the support for this. And today's speaker, I should thank specifically Dr. Sheeja madam. She had agreed for this meeting. During the pedicon only we met madam, and after the pedicon only I discussed about this. Thank you, madam. And I should thank our MC, Dr. Sakla, for agreeing for this ceremony in the short notice. And finally, I should say a big thank you for each one of you from the various medical colleges who have joined here. And also I know that various colleagues, seniors have all joined here. Thank you all. So have a happy learning. Also over to Sheeja madam.
Thank you, Nisha. Good evening, everyone. First of all, I thank the team IEP led by Shimi sir last year and this year by Dr. Riaz, helped by Gobi Mohan, Dr. Binukutan, and definitely the TIPS team of Johnny Sebastian sir and Dr. Nisha Krishnan for giving me this wonderful opportunity. So coming straight to the topic, that is the job given to me. Please enable screen sharing. I cannot share the screen. Co-host ആക്കാവോ എന്നാലേ ഷെയർ ചെയ്യാൻ പറ്റുള്ളൂ.
ആക്കിയിട്ടുണ്ട് മേഡം.
താങ്ക് യു രഞ്ജിത്ത്. So we come to the topic, that is recognition of a sick child. So what do we plan to do in the next 45 minutes or so? So we would see that how to recognize a sick child in a busy OPD or ER, how to proceed with a systematic assessment, identify problems in children, and how to stabilize. So before we proceed further, the one question I would like all of you to remember is that, is child a miniature adult? Well, the answer is no. Child is definitely not a miniature adult. There are a lot of physiological differences between a child and an adult. Yes, the disease spectrum is different when it comes to adult and child. An adult, you usually see diseases of an aging system, right? You will have a stroke, you will have an MI, you will have a chronic kidney disease. Whereas in a child, commonly infections are the commonest cause why they come to the hospital. But again, how a baby reacts to infection and how an adult reacts to infection are also different. On one side, a baby cannot tell you what is wrong with it. On the other side, for example, a baby in shock, if the patient wants to increase the cardiac output, it has to increase the heart rate. An adult who has basic heart rate is 70 can easily make it 140 and have a good cardiac output. But a child who's already has a heart rate of 130, 140 cannot make it 260 or 230 because there will not be any diastolic filling. Similarly, BP falls early in a septic shock in an adult, whereas in babies, usually the systemic vascular resistance is high, as a result of which only late in the disease, the BP falls. And once the BP falls in a baby, the cardiac arrest may only be minutes away. So it is important for us to realize that babies or children are not miniature adults. Now, why do you mean by looking recognition of a sick child? Only sick children come to hospital, right? So why this topic, that recognition of a sick child? What we mean by the topic is that we want you to recognize who is sicker among all those who have come to the hospital, who is having a major physiological impairment, because whatever be the reason the child has come to hospital, be it trauma, infection, toxins, or anything, ultimately the disease will cause a physiological impairment, and only then can it lead to a cardiac arrest. Sudden cardiac arrest due to arrhythmias are extremely common in children compared to adults. So normally their cardiac arrest or a mortality or a significant morbidity is preceded by a physiological impairment. So in today's talk, we are exactly going to learn how to identify these life-threatening physiological impairments. So how do we learn this? We will learn today how, by just looking at a child, you're able to say whether the child is having a serious illness or not. By just asking a few questions to the mother, you're able to gather whether the child has a major organ impairment or not, and how by doing a quick 5-minute assessment, you're able to pick up a major abnormality in a critically ill child. So now you have here 4 children. Whom would you think you would call first to examine? They're all waiting in the queue in your ER. One is crying, one is angry with you, one is sleeping, one is happy with the mother. Whatever be the reason, how do you look at the children? When you look at a child, your mind should process the appearance, breathing, and color. Appearance doesn't mean whether the baby is looking cute or not. Appearance means how is the baby? If the baby is interactive with the mother, whatever the mother says, yes, the baby can wait in queue and come when the time comes. If the baby is crying, it may be because he didn't like you, but it may also be because the baby has a significant illness, maybe a surgical abdomen, maybe a meningitis, because of which he has an inconsolable cry, which is a danger sign. So whenever you have a baby who's crying uncontrollably, always ask the mother, can you please feed the baby and come? Only then I can examine. But if the mother says, no, my baby is not sucking at breast, he continues to howl from quite some time now, then you know it is definitely a serious illness and you need to see the baby ahead of the line. And of course, a sleeping baby, ensure that the baby is really sleeping and he is not drowsy. From far itself, you can make out if the baby is having a breathing problem, and of course, color. So look whether the baby is looking pale, cyanosed, or what you see in the second picture is what the skins are all mottled, which again means that peripheral perfusion is poor. So just by looking, you're looking at the appearance, breathing, and color. We don't want you to diagnose what is wrong with the baby. We just want you to be able to say that if one of this is not abnormal, the child is possibly having a life-threatening illness. So now the baby has come to you. So now the baby has come to you, and when you ask the mother what is the problem, the mother says it's just fever of 2 days duration. Now a fever can be a viral fever can be a forerunner of meningitis. How do you differentiate between the two? How do you know that this is not a septic shock the baby is having, or this is just a viral fever? But simply asking a mother a few questions. Ask the mother, how is the baby in between fever? Children don't have anticipations like us. We think my head is aching, my stomach is aching, I am feeling tired. No, babies don't have that. When they have fever, they would be extremely dull and would just lie down. But the moment the antipyretic acts, moment the paracetamol brings down the fever, the baby would be running about in the house. So ask the mother specifically, how is the baby in between fever? If the mother says the baby continues to be lethargic in between fever episodes also, that is a danger sign. That child baby needs to be seen immediately. Ask about breastfeeding. You should know that however sick a baby is, if it is a breastfed baby, the baby will refuse feeds, but baby will continue to take breast milk. If a baby is not taking breast milk, that is a very big danger sign. Yes, sometimes it may be due to a nasal block, the baby is finding it difficult to suck, but sometimes it may be something much more ominous like a septic shock or a meningitis, which makes the baby refuse the most important feed of its life, that is the breastfeed. So baby who doesn't suck at breast, even in the middle of the night, needs a hospital visit and needs a thorough assessment. Now, you have not checked the pulse or BP. Just ask for the urine output. If the mother says the baby is passing normal quantity of urine in the normal frequency, rest assured you are not dealing with a septic shock, because the best method to know if your tissues are getting perfused is to know the urine output. And of course, you can ask and look for any change in breathing pattern. Even if you don't remember the respiratory rate cutoff, you can ask the mother, are you finding anything difficulty in the breathing? And you can also ask whether the hands feel cold to touch or not. So just imagine simple 5 basic questions. It is giving you clue regarding a CNS derangement, a CVS derangement, as well as a respiratory derangement. So once you have asked these questions, and if anything is red, that means the child requires a very immediate attention. And now when you are examining the child, please go by the order. The A, B, C, D, E is important. Look at the airway. Is it clear? Is there any sounds? Are you hearing a stridor? Look at the breathing. First, see if the baby is breathing well. Then see if the baby is breathing too fast. Then see if the chest excursions are normal. And then finally auscultate and see whether you can make out any added sounds, and of course the saturation. Then looking at the circulation, always feel the baby. Is it feeling cold to touch? Feel not the body, but feel the extremities, feel the palm, feel the sole. If it is feeling cold, yes, it may be because the child came in an auto and it is a rainy day, he's feeling cold. But it can also be that the patient is in circulatory shock and that is why the extremities are cold, or the baby is having a hypothermia. So always feel the extremities. And then feel the pulse and the pulse volume, especially peripheral pulses. Peripheral pulses means your dorsalis pedis, your radial, these are the peripheral pulses. Feel them. If they feel as well as the central pulses like your femoral or carotid, you know that the patient probably does not have a circulatory compromise. In disability, we don't want you to look the whole of the CNS examination. We just want to look at the GCS. Now, GCS also has many parts. Now, even in an emergency, you don't have to even go through the whole of GCS. Just write A, V, P, Q. What is A? A means the baby is alert. V means the baby is voice responsive. P means baby is pain responsive. And U means baby is unresponsive. So write AVPU, and whichever the baby is showing, put that as a circle. If you have a baby who's having an inconsolable cry, don't write A. It has to be V. When you write A, that means this baby cannot have a better sensorium than the baby is having currently. Then if the baby is sleeping on the mother's shoulder, but the tone is lost, always remember, even when you put the baby to the shoulder, the limbs always have a tone. They don't keep it completely extended. It's usually partially flexed. If it's completely extended and flabby and hypotonic, definitely that is a danger sign. And look at the pupils. Pupils means anisocoria is abnormal, abnormally small pupils, abnormally dilated pupils, they're all abnormal. And don't forget to look for blood glucose in every baby who comes to you and who is sick. And of course, last but not the least, expose the baby and quickly see if there are any rashes, any bleeds, any fractures that you don't want to miss. And then cover the baby fast also. People say that you can do this whole thing in 1 minute, but if you're checking the BP also, I would say you can do the whole thing simultaneously, at least in less than 5 minutes, definitely. And at the end of the primary assessment or at any time, you identify a problem, immediately intervene and then proceed. For example, you find that the patient is hypoxic, immediately give oxygen and then see what is the wrong with circulation. And then come back and see whether the oxygen that you have administered has led to an increase in saturation or not. This process has to go again and again and again. That is assess, identify, intervene. Assess, identify, intervene. This has to be continued. And at the end of this primary assessment, you should be able to say if the child is having a respiratory distress or respiratory failure, is the child having a shock? If it is a shock, whether it is a compensated shock or a hypotensive shock. A hypotensive shock means BP has fallen. A compensated shock means baby is showing some features of shock like a tachycardia, poor perfusion, but BP is still maintained. And then see whether the baby is having a neurological dysfunction. A neurological dysfunction, if you have a pupillary abnormality, you write it as brainstem dysfunction. If it's just that the baby's GCS is low or the patient is drowsy, it may be due to shock, it may be due to hypoglycemia, then you write it as cortical dysfunction, which may be primary because of a brain pathology or it may be secondary because of a systemic pathology. So at the end of a primary assessment, this is what we want you to identify. And after you have done the primary assessment and you have provided the immediate interventions, go back to the mother, take a focused history, that is sample history, signs and symptoms, history of allergy, what are the medication, any medications child is on, any past medical history that is significant, when did the baby take the last meal, and what were the events exactly that led to the baby coming to the hospital in this state. So take a quick focused history and then do a focused examination. That is, you do a head-to-toe examination. This time, when you're doing a head-to-toe examination, you're taking a much more time. You're doing a much more detail, especially those parts you would be looking into, which you did not look in the primary assessment. We did not look at the eyes, ears, nose, throat. You can look there. You can look for the lymphadenopathy. As you come down, you can have a more detailed examination of the respiratory system or CVS if you think that is the primary cause. Coming down, you would look for the hepatosplenomegaly, the genitalia, and the other lymph nodes also, and also bones and joints. So that is how, and after you have done a focused examination, you proceed to send an investigation and finally reach the diagnosis. So even though I've spoken so much, in practice, this takes very little time for you to do. Now, what do you mean by airway? The A, B, C, D, E. The first thing was airway. So what do you mean by airway? Airway means you may have to ensure that the air is able to enter the lungs. So how can the airway be abnormal? The airway can be abnormal if the patient has secretions. Naturally, you will have this secretions coming from the mouth. That means the airway is obstructed or partially obstructed and breathing may be difficult. So in that situation, definitely suction the mouth and also the nose. And usually we recommend a small size catheters when you're using you're suctioning the nose. That is at least half the nasal diameter, the anterior nail diameter is recommended. But when you are suctioning the mouth, it is always preferable to use a larger size catheter. Commonly 10 or 12 size catheters are preferred because so that if the baby is, say, vomiting, you can take out the feed immediately. If you're using a very small catheter, it is going to take a long time to clear the airway with that. Similarly, if it's a big child and he has particulate matters in the mouth, he is vomiting out the food that he has taken, then the rigid catheter, that is a Yankor catheter, would be a better option. And Yankor catheter would also be better when the secretions are copious, say a patient with pulmonary edema. Then you find that a lot of secretions are coming, a lot of frothing is coming, and you suddenly want to suck it up, clear the airway, then Yankor suction. Yankor suction is the same thing that you would have seen your teachers using it during cesarean to suck the amniotic fluid. So that can be used for suctioning the mouth when the secretions are too much. So once you have cleared the airway, you need to see that if the patient is unconscious, always remember that the tongue can fall back and obstruct the airway. So you need to do the head tilt chin lift maneuver, and you can see how beautifully the tongue moves forward and the air can flow in. And similarly, if the patient is suspecting a cervical spine injury, someone with a hanging, someone with a drowning, someone with a road traffic accident, you have not ruled out a cervical spine injury, then you cannot do a head tilt chin lift maneuver, because that may make the cervical spine more unstable. And then you would do this jaw thrust maneuver. So you can see here, someone is pressing on the maxilla and angle of the jaw is pushed forwards to open up the airway. And if the patient is unconscious and you want to transport the patient, you can always use an oropharyngeal airway to really keep the airway patent. Now coming to the breathing. So once you identify a problem in breathing, that is commonly the commonest thing that would require an intervention would naturally be an hypoxia. So you have many oxygen delivery devices that are used to deliver oxygen. But we need to know that the most important one is the non-rebreathing mask. If any one of you have not seen it, when next time, tomorrow when you're going to the hospital, please ensure that you have seen this particular device. Because yes, you need to connect at least 10 liters per minute of oxygen to it. You have to ensure that the bag inflates. The importance is it can deliver 80 to 90% FiO2. This is the device which can give you maximum oxygen. So you are sitting in a casualty and you are finding a child hypoxic. The first device that is going to bring up the oxygen fast in a breathing hypoxic child would be a non-rebreathing mask. So start a non-rebreathing mask. If you find that on an NRM, the patient is saturating more than 98%, then definitely you can think of using a face mask. When you're using a face mask, the flow rate should be minimum 5 liters per minute. Why? Because when you're using a face mask, you are exhaling also into the face mask, which basically means that the carbon dioxide rebreathing would happen if the flow of oxygen into the mask is less. So whenever you're using a face mask, the minimum flow is 5 liters per minute. It would give you around 40 to 60% FiO2. And most comfortable for the babies is nasal prongs, because once you keep the nasal prongs, when you're keeping it, the baby may be irritable. But once it is there, then the baby is comfortable, he can feed, he can play, and he's not hypoxic. So nasal prongs is something we prefer. And always the target saturation is 94 to 98%. You never want 100% saturate on and supplemental oxygen. But when you say that the patient is saturating 100%, remember pulse oximeter cannot measure hyperoxia. So pulse oximeter, when it says 100% SpO2, it may mean that FiO2 is 80 or 100. It may also, FiO2 alla, PaO2 may be 80 or 100. It may also mean that PaO2 is 400. So you don't want hyperoxia. Hyperoxia is harmful. So always target a saturation between 94 to 98. That is, use the minimum oxygen, which would give you that saturation. And when you keep the nasal prongs, for an infant, the maximum flow is 2 liters per minute. For a child, it is 4 liters per minute. For an adult, you can go even up to 6 liters per minute. Now, why is this difference? Why for a baby, you're giving 2, for a child, 4? The reason is because that is the amount of flow that the patient's paranasal sinuses can humidify. So that, and humidification is extremely important. If you give too much of dry air or oxygen through the nose, all the mucous membranes are going to be damaged. Your cilia is going to be damaged. In fact, you may be precipitating or you may be instigating a secondary infection. So the flow rate should also be kept in mind. And here you can decrease the flow as much as you want, no problem. Because when you're using nasal prongs, there is no carbon dioxide rebreathing. Just titrate the flow according to the need. But if your patient is not breathing, these are not the options. These 3 options are only for a breathing child. And if patient is not breathing, then it is a bag and mask ventilation, so that you're taking care of the air going in. In the other scenario, patient is breathing, you're only taking care of the quality of air that is going in. Here, now you're ensuring that air itself is going in. Here, remember one thing, if that particular bag at the back, which is known as the reservoir, if that is connected, you're going to get close to 100% FiO2. And if that is not connected, your FiO2 may be anywhere between 30 to 50. So it is important that it's a hypoxic patient when you're ambuing, you do use the reservoir also. So now let us see this child. It's a 3-month-old child with fever and URI and breathing difficulty. You can see the vitals has been given to you. It is 60. It is tachypneic, tachycardic with a saturation of 92%, and auscultation is showing bilateral crepitations and wheeze. So what comes to your mind? 3-month-old baby, URI, fever, breathing difficulty, bilateral wheezes and creps. The commonest diagnosis would be a viral infection like a bronchiolitis. And because the saturation is 92, you would definitely like to keep an oxygen by whichever method you want to ensure that the saturation is more than 94%. There are guidelines we recommend saturation at 90% as target, but commonly we are happy with a 94% saturation. Now, the same child, if you go a systematic assessment, a primary assessment, see the difference. So when you did the systematic assessment, you realize that airway, there are secretions, so you immediately suction. Breathing, you find, yes, the child is having tachypnea, is having an SpO2 of 92%. You also get the oxygen. Then you proceeded to circulation, you realize that extremities are cold, CFT is 3 seconds, dorsalis pedis is feeble, pulse rate is 160 with a hypotension. So immediately you started a normal saline bolus. So now you realize that it is not just a respiratory problem, there is also a circulatory compromise. Moving down to disability, when you check the blood glucose, you realize that the child is drowsy because the blood glucose is only 28 milligram per deciliter. So immediately you give a D10 2 ml per kg IV you prescribe. Then you went back to the temperature, you found that the patient is febrile and 101 degree. So immediately you kept a paracetamol suppository. Just look at the number of interventions that you could do for this baby when you did a systematic assessment. It didn't stop there. Then after the primary assessment, you immediately moved to the secondary assessment. And when you went to the secondary assessment, history did not reveal anything more. But when you did the head-to-toe examination, you picked up a hepatomegaly 5 centimeters. So what happened now? You have a baby, respiratory distress, hypotensive shock, hypoglycemia with hepatomegaly that rung a bell. Maybe I'm not dealing with a pure respiratory one. So you immediately ordered an X-ray, and what you're seeing is a huge cardiomegaly, revealing that what you initially thought as a bronchiolitis finally turned out to be a cardiogenic shock. So what is the difference? The moment you realize that those wheezes and crepitations were not due to a respiratory infection, but these were features of pulmonary edema, you immediately said, stop the fluid. You put the baby on a CPAP or an NIV. You started because hypoglycemia, you started him on a maintenance fluid, and you decided on an inotroph. So it is important. So I hope this particular scenario tells you the importance of why going through all the steps of the primary assessment and the secondary assessment is important to really reach a diagnosis. Believe me, if you do this, it's a very, very rare chance that you would go wrong. Final diagnosis will be arrived appropriately if you follow the steps properly. So revising again, the moment you see a baby, just by looking at the baby, form an initial impression, thinking about the appearance, breathing, and color. And once the baby comes to you, do a quick primary assessment. Within taking 5 minutes, you should be able to say the physiological status, that is whether there is a distress or failure or shock or a neurological dysfunction, and then proceed to secondary assessment, including history and examination, send important investigations, and reach the final diagnosis. So these 4 steps are important in any child that you encounter. Now let us see a few cases that you may encounter in your day-to-day practice. So respiratory complaints are the commonest symptoms with which children come to the ER. So when it comes to respiratory emergencies, remember that what can you encounter? What can cause a breathing problem in a baby? It may be an upper airway obstruction. It may be a lower airway obstruction. It may be a lung parenchymal disease, or it may be a disordered control of breathing. So if you have a baby with a respiratory disease, these are the only 4 physiological or anatomical causes that can cause a respiratory problem in a baby. Now, how do you know that your patient with having a breathing difficulty may be having a respiratory distress or a respiratory failure? Remember that if a child is having respiratory distress, he is going to be will not have any serious issue probably for the next couple of hours. But if the patient's diagnosis is respiratory failure, he can go into cardiac arrest at any moment. When we say respiratory failure, what immediately comes to our mind is a baby who does not breathe. Remember, not breathing alone is not respiratory failure. Any baby with a saturation less than 90%, any baby who's drowsy in a respiratory illness is also respiratory failure. Why do I say so? We say a patient is in respiratory failure if the PaO2 is less than 60 or a PCO2 is more than 50. PCO2 cannot be measured by your pulse oximeter, but PCO2, when you find that the PCO2, when you find that the baby is drowsy, that may be an indication of carbon dioxide narcosis. And a flash capillary refill may also be an indication of carbon dioxide narcosis. So hypoxia, drowsy child, apnea, bradypnea, all indicates respiratory failure requiring immediate intervention. It doesn't always mean you want to intubate and ventilate. That you would do for any apnea or hypopnea. Others, you would like to give them a respiratory support. Now, so we now identified the severity of illness. Now you want to know, among those 4 kinds of emergencies we said, where is the problem? So the first step is look at if the patient has an increased work of breathing, look at the site of retraction. If you find that your baby is having, as you can see here, suprasternal retractions. I hope you're able to see it here, the suprasternal retractions. Or if you see sternal retractions, it means that it is a major airway obstruction which is causing the problem. That is, the patient may be having a laryngotracheobronchitis, maybe a patient may be having a foreign body in the larynx or something in the major airway in the upper mid trachea. That would only cause a stridor and a suprasternal retractions. On the other hand, if you find that your baby is having intercostal retractions, especially when you have lower chest indrawing associated with abnormal sounds like grunting. What is grunting? The patient strains with every breath. This particular sound, if they make, remember, it is a danger sign. The patient grunts because so that he can keep the alveoli open. It is expiration against a partially closed glottis so that the functional residual capacity is maintained and the oxygenation is maintained. So a grunting in a small child indicates pneumonia unless otherwise proved. You may have occasionally baby grunting due to very high fever or even in metabolic acidosis, but classically grunting always indicates a pneumonia. Then you can have patients with subcostal retraction. If you look carefully at the way this child is breathing, you can make out that inspiration is short and expiration is long, which again indicates that the patient probably has a lower airway obstruction, meaning something like a bronchial asthma. So just by looking at the site of retractions, the type of retractions and the sounds it makes, you're able to somewhere find a reason why your baby is showing a respiratory distress. Now moving on to sternal and suprasternal retraction. You saw the first baby, right? Had a suprasternal retractions. I already said it is due to a major airway obstruction that is either a larynx or trachea. Now, what can cause an obstruction? How do you know? If the complaint is acute onset, totally normal child suddenly develops a stridor, beware, it may be a foreign body. It may be a small baby who's not even learned to crawl now, but the elder sibling may have put something in the mouth. So sudden onset stridor, always think of a foreign body. Insidious onset has a URA, low-grade fever, barking cough, and then goes on to develop a stridor. Think about a laryngotracheobronchitis. If a patient has a stridor-like sound, along with that patient looks toxic, has drooling and dysphagia, think of something painful there like epiglottitis. Thanks to the Pentavac vaccine, this is nowadays very, very rare. The patient complains of throat pain, dysphagia, and fever, retropharyngeal abscess. Retropharyngeal abscess very rarely cause stridor because unless it is that huge, it doesn't cause. Normally, more commonly, it would present to you with a dysphagia. So now among this, the commonest one that you are going to encounter would be a croup. And this is how it looks like. I hope you heard the sound. That is exactly the sound which you mean by a stridor. It is an inspiratory sound. So usually development of a stridor 1 or 2 days after a fever and URA indicates that the patient is having a laryngotracheobronchitis. Usually, and it usually starts with a brassy cough and subsequently develops a breathlessness. The danger signs of croup is a stridor in a calm child. Why stridor in a calm child is a danger sign and stridor in a crying child is not a danger sign? When a baby is crying, it is drawing in a lot of air through the narrow larynx, and only then the stridor is appearing. While a baby who is sleeping and still has a stridor, that means even a normal flow of air through the same aperture is causing a sound. So that means it is more narrower, just like the whistle you have to remember. So unless the aperture is too small, it will not cause a sound when the flow is normally passing. So stridor in a calm child is always a danger sign. But beware, children also have laryngomalacia. So always ask them before you jump to a conclusion that did the baby have this sound previously also? And so because that is a congenital anomaly that usually gets most of the time improves as the child becomes bigger. Then marked retractions also, and hypoxia is a danger sign, but it's a very late sign. So unlike other respiratory pathologies where the hypoxia sets in early, in a laryngotracheobronchitis, it is a very, very late sign, and altered sensorium naturally in any case would be a danger sign. Now, how do you treat? You're sitting in the casualty in the middle of the night, you've got all the typical answers, and the patient is having a stridor. Then don't force the baby for anything. Keep the baby in the mother's lap itself, position of comfort. If the patient is having hypoxia, give a free flow oxygen in the way the baby wants. Don't disturb. The drug of choice here is dexamethasone. It is 0.6 mg per kg, oral or intramuscular. Why it is written intramuscular? Because you're going to give this drug only once. But this dexamethasone is going to act only 4 hours later. What do you do for the baby right now who is so dyspneic and has a stridor at rest? Give him an adrenaline nebulization. Adrenaline nebulization, usual dose is 0.5 ml per kg. But now commonly we say that you can simply take 5 ampules of adrenaline and nebulize it. Now what will this adrenaline do? Adrenaline causes action on alpha, beta 1, beta 2 receptors. Here, you want the action of alpha receptors. Alpha receptors cause mucosal vascular constriction, because of which the edema comes down. So adrenaline, you will find dramatic response. You've given the steroid, it is going to take 4 hours. But the moment you give adrenaline, after 20 minutes, you can find that the patient's distress has come down, the stridor has significantly decreased. So, but a few things you need to know regarding adrenaline. The duration of action is only 60 to 90 minutes. So a child who's come to you with a stridor, you have given an adrenaline nebulization, you find that the patient is better, please don't dispose the child, because the stridor can reappear once the effect weans off. So any child who has received adrenaline should be observed for at least 2 hours. If stridor reappears, you can always repeat adrenaline. You can even give adrenaline every 20 to 30 minutes if the patient is distressed. But at the end of 4 hours, the child still has stridor and does not show significant improvement, that is an indication to admit, because by 4 hours, the steroid action would have come. And even in spite of this action of steroid, if the stridor has not come down, that means the disease is quite severe, requires admission and further management. So now going to the second case, the 6-year-old child who has breathlessness. His saturation is maintained but has tachycardia 180 per minute, respiratory rate 56 per minute, and auscultation is revealing peace. Now what would you do? And house urgency, we were all called as RV doctors. For anything and everything in child who comes with a breathlessness, and I would say for anything the respiratory complaint, immediately the action was giving a nebulization. So before you jump to the conclusion that this child is having a wheeze, is having an asthma exacerbation, there are 3 things you need to ensure. Number 1, are you really dealing with an asthma? Remember, wheezing can happen due to aspiration, wheezing can happen due to foreign body, wheezing can happen due to a pulmonary edema. So there are umpteen number of causes, and anaphylaxis can manifest as wheeze. So ensure that you're indeed dealing with an asthma. Ask for previous history, ask for family history, make sure that you're hearing the wheeze bilaterally. Then the second job is to see how severe is it. Is it a severe life-threatening attack or is it a moderate attack? And third is definitely ask for any asthma mortality risk factors. Is there a possibility that this child may come back tomorrow with a very bad wheeze? So how do you know that? At least ask them, is there a previous history of admission to the ICU or previous history of admission or ventilation, which usually indicates there is a risk factor for mortality. Those children should not be disposed of quickly. Now, how do you know how severe it is? Just look at the saturation, look at the heart rate, and look at the respiratory rate. Remember, tachycardia is a feature of severity. An infant, if a young child is having a heart rate more than 180, do not resist giving, do not have any hesitancy in giving a beta-2 agonist nebulization in a non-asthmatic, because tachycardia indicates a severe attack. And you will find that once you give the nebulization, the distress comes down, the tachycardia is the one that comes down first. So severity can be assessed by just looking at the heart rate, the SpO2, as well as the respiratory rate. Now, how do you manage? Definitely, when the child is coming in severe distress and hypoxia, give an oxygen-driven nebulization. That means you're not going to use the standard nebulization. You're in fact connecting the oxygen flow meter directly to the nebulization chamber at 6 liters per minute. It will give you, see to it that the fumes are coming. Only then it is effective. And your target saturation is 94 to 98%, means once the saturation improves, there is no need to continue nebulization with oxygen. You can continue nebulization with the ordinary nebulizer itself, because high oxygen has been associated with increase in PCO2 in patients with severe exacerbation. What is the dose? If the baby is less than 20 kilogram, you need to give 2.5 milligram of salbutamol or 0.5 ml of salbutamol solution with 3 ml normal saline. If the child is more than 5 years or more than 20 kg, then 1 ml or 5 milligram. 5 milligram means 2 respules. 2.5 milligram means 1 respule. If you're working in a hospital where the 30 ml bottles of salbutamol is available, then it is 0.5 ml and 1 ml. And add normal saline to it so that the total volume is at least 4 ml, and ensure that the fumes are coming. That is very, very important. And if your child is very sick, you can combine it with ipratropium bromide. That is when you're giving the salbutamol nebulization. That time in the same chamber, you can add ipratropium bromide. For a small child, 0.5 ml, and a bigger child, 1 ml may be added. And you can repeat nebulization 3 times at 20 minutes interval. So you're giving a salbutamol with ipratropium now. 20 minutes later, you're again giving a salbutamol with ipratropium. Like 3 times you can repeat it and reassess the child. Remember, ipratropium bromide is usually recommended only for the first hour. And if the patient continues to have wheeze even after first hour of nebulization, then continue with salbutamol nebulization alone. Ipratropium is not indicated. Ipratropium, even if it's given, it is given only 4 to 6 hours. Then one word I would want you all to remember, that if your child does not have features of severe exacerbation, that is not much of tachycardia, the patient is at home, or you are working in a peripheral setup, or the patient does not have hypoxia, always remember MDI is superior to nebulization. In what way MDI is superior to nebulization? MDI, the particles are very narrow, so the drug distribution is better. Here you can see, when you're using an MDI, the drug distribution is close to 20%, whereas when you're using a nebulizer, the drug distribution to the terminal respiratory bronchioles is only 12%. So MDI causes less of tachycardia and more uniform distribution of the drug when compared to nebulizer. So then why do you use nebulizer when the child is very sick? We're using nebulizer because you can give oxygen along with it. We are using nebulizer because the dose or the amount of drug that you give in a nebulizer is far higher than what you give in an MDI. That is also exactly the reason why nebulizer causes more tachycardia and arrhythmias, whereas MDI causes less tachycardia and less arrhythmia. MDI, 1 puff is only 100 microgram, and nebulizer, your 1 ml is 5 milligram, that is 5,000 microgram. So that is the difference between the two. So, and do not forget giving steroids. Remember, asthma is a chronic inflammatory disease. There is no treatment in asthma without steroids. Whether you are working by sitting in an OPD and seeing a mild exacerbation of asthma, or you're sitting in a casualty seeing a severe exacerbation of asthma, both these groups require steroids. A very small dose of prednisolone, 1 to 2 mg per kg, given for 3 days is enough, but that should be given along with the beta agonist. Beta agonist alone should not be given. Too frequent use of beta agonist causes downregulation of the beta-2 receptors, making the exacerbation more difficult. And when you use beta agonist alone without steroid, it increases eosinophilic infiltration of the bronchial muscles and in fact can worsen the disease itself. So it is important. Always remember, steroids are mandatory. There are many different kinds of steroids people use, but oral, use prednisolone. If the patient is too sick, use hydrocortisone. The dose you can use 4 mg per kg 6 hourly can be given. In some guidelines, just prefer 1 mg per kg 6 hourly, but commonly what we use is 4 milligram per kilogram per dose 6 hourly to a maximum of 100 milligram. So with that, now we come, so the second case is also over. Now we have a third child. The patient is having, again, another child having a fever of 2 days duration, has come to you with respiratory distress. Air entry is equal. I forgot to have the video. So basically what is here, air entry is equal bilateral. There are no added sounds and SpO2 is 100%. What would you do? So this particular child, in fact, was seen in the casualty, is admitted to the ICU because of the respiratory distress. The prongs is there in the nose and the patient is breathing, has a very tachypneic breathing, but saturation is 100. And when you auscultate, you don't get any added sounds. What is your diagnosis? Why is your baby breathing deep and fast, but you're not finding anything in the X-ray? You're not finding anything when you're auscultating. And as usual, you are landed up giving nebulizations also, but naturally it didn't affect. This is that subgroup of patient. You're probably not dealing with a respiratory pathology. Probably you're dealing with a metabolic acidosis. Commonly, we receive children with diabetic ketoacidosis being treated as asthma, and then they land up to you and you realize it's a DKA. Sometimes you have children with inborn errors of metabolism with metabolic acidosis. They may be misdiagnosed again as a respiratory pathology, and they may be given nebulization. So please remember, a baby who's breathing fast without any effort, but large tidal volumes, and you're not getting any sounds anywhere, please think of metabolic acidosis. Now coming to the second case, fifth case, a 1-year-old child with fever of 2 days duration. You have done a quick primary assessment. The problem here is the child has poor activity and poor feeding. You can see the tone of the muscle baby is so bad, the abdomen is distended. You can even see the capillary markings on the abdomen, which again means that the capillary perfusion is poor. There is some erythema in the axillary region, venous access extremely difficult. The child is having a scalp access here. And when you examine the child, you realize that the extremities are cold. You can see the CFT is prolonged. Pulses are feeble. Pulse rate is 180. BP is 50 systolic. Now, the question is, you know what you're dealing with. You are dealing with a child with fever with features of shock, hypotension, tachycardia, cold extremities. Definitely, you're dealing with hypotension. What is hypotension? If a BP less than 70 in a baby less than 1 year is hypotension, and 70 plus age into 2 for anyone more than 1 year is also hypotension. Even if you don't have a BP cuff, even if you don't check the BP, if you find that your BP is having a rapid thready pulse with cold extremities and a CFT more than 3 seconds, take it as hypotension. That is what WHO says. Now the question is, you know that you're dealing with probably a septic shock. Is it okay for me to refer this child immediately, or is it okay for me to admit the child without doing anything because the child definitely looks sick? Now, you need to remember that when the child initially presents to you in a septic shock at that particular moment, when the patient's perfusions are poor, but still the tachycardia is there, it is a time your heart is beating fast to compensate for the shock, and most of your organs are still getting perfused. At this moment, if you're not going to act, what is going to happen? In shock, why does the BP fall? The BP falls because the infection has damaged your capillary endothelium and the fluid has leaked into the interstitium. So if you don't give a fluid at this time, the leak is going to continue. As the leak continues, the intravascular volume decreases further. As the intravascular volume decreases and the flow becomes more sluggish, the endothelium gets damaged and it acts as a nidus for thrombus formation. Once this happens, there is microthrombi forming in the vessels, in multiple vessels in major organs, and this is going to cause these organ damages and ultimately lead on to multi-organ dysfunction and death. So remember, once a patient develops a shock, every hour delay in correction of shock increases mortality by 50%. So it's very, very important that the moment you diagnose a hypotension, you start the fluid. Which fluid would you give? Please do not use dextrose containing fluid. The fluid recommended is normal saline or ringer lactate. The only condition where you use a dextrose containing fluid for resuscitation is a child with severe acute malnutrition, where you use half DNS. Otherwise, it is always normal saline or ringer lactate. Ringer lactate is preferred in diarrhea because in diarrhea, you're losing bicarbonate, and the lactate in ringer lactate acts as a source for that. Whereas normal saline is usually preferred in all other situations. You have another newer IV fluid by the name Plasma Light, which is more similar to your plasma and is now the preferred IV fluid of resuscitation. So I would say, remember normal saline. How much time do you have to get an IV line once you have decided to give a fluid bolus? The answer is you just have 3 attempts and 90 seconds. You need to secure an intravenous or access within 5 minutes. So if after 3 attempts, your child is in shock and you're not able to give a fluid, please do not hesitate to put an intraosseous slide. This is something every resident should learn before they complete their house surgency, because this does not require any great skill. This only requires you to know the correct technique of insertion, which can easily be done and can be quite life-saving in any emergency. You can use a bone marrow aspiration needle. If that is not available, you can simply use a blood set needle, and that will be life-saving. So this is one skill that everyone needs to learn. And any child in hypotensive shock, it is important you provide oxygen, preferably by NRM. Check the blood glucose. If glucose is less than 60, please correct hypoglycemia, because if hypoglycemia is not corrected, shock will also not get corrected. Start the normal saline bolus, 10 to 20 ml per kg, give it over 20 to 30 minutes. And do not forget to give the first dose of antibiotic within the first hour, because every hour delay in administration of an appropriate antibiotic in a child with septic shock increases the mortality by 7.6%. So all these 4 things should be done in every child in whom the diagnosis of a hypotensive shock is made. Remember to document the vitals before you are giving an IV fluid and after you have given an IV fluid bolus, because if you find an improvement, that means he may require further boluses. If you find a deterioration after a bolus, you have to go back and examine the heart again, examine the liver size again. Maybe you are dealing with a cardiogenic shock, which may necessitate starting an inotrope early. Now, coming to a neurological dysfunction. So this is a 6-month-old child. You're sitting alone in the casualty. The resident has gone to have a tea, and the child has presented to you with seizure. Now the question is, should you treat or should you wait? So we had a similar situation a couple of years back. A 6-month-old child presented to a local hospital morning at 6 a.m. with seizures. So the junior doctor sitting there, pediatrician not available, immediately referred the child to a tertiary care hospital. By the time the child reached the hospital, it was more than 2 hours. And at that time also, the child's seizure was still continuing. The child was hypoxic, hypotensive, with a glucose of just 24 milligram per deciliter. The child was hypoventilating, necessitating an immediate intubation. You managed the seizures with anticonvulsants. You corrected the shock. You corrected the GRBS, but the patient's pupils remains dilated and fixed. And the GCS was 3. So you thought, what has gone wrong? So an emergency CT was taken, and this is what the CT shows, that is severe hypoxic brain damage. The question is, could it have been prevented? The answer is, I do not know whether it could have been completely prevented. If this was a case of encephalitis, it may have progressed like this, and we might not have been able to salvage the child. But it can also be that this child could have been prevented. Maybe it is a bad hypoxic encephalopathy, hypoglycemic encephalopathy, hypotensive damage to the brain. All this has contributed to the cytotoxic edema the child has developed, and which has resulted in a brainstem herniation. So remember that When you see a child with seizure, 75% of the seizure terminate of its own within 5 minutes. But if a child with seizure is coming to the hospital, the 5-minute window is already over. You need to treat it. So outside, you're seeing a child just throwing a seizure. You can simply see that the child is not hurting itself. The child is not aspirating. You're putting them on a lateral position so that the secretions are coming out. You can wait for 5 minutes, no problem. But if the seizure is lasting for more than 5 minutes, it needs to be treated. Because any seizure that lasts for more than 5 minutes, the chance of it lasting for more than 20 to 30 minutes increases by 6%, and any seizure that lasts for more than 30 minutes can cause a neuronal injury. And remember also that the longer the seizure lasts, it will be more difficult for you to control the seizures, because when you give a medicine, especially the benzodiazepines, they act on GABA. And when the seizure, GABA are the inhibitory receptors. When you go on, when the seizure continues, the GABA receptors becomes internalized, because of which your benzodiazepines may not be effective. So what should you do? The moment you have a child with seizure, immediately see to it that he's not aspirating. Every child who has a seizure more than 5 minutes needs an oxygen. Always start oxygen, because there will be a disordered control of breathing while the seizure is happening. If you need to refer this child to a tertiary care hospital, then put an unconscious child, do put an oropharyngeal airway and then put the oxygen and refer, so that he's not biting and he's also not, tongue is not coming and blocking the airway. That is important. Always check for the glucose and connect the glucose. In a child, in a newborn, we say less than 45 is hypoglycemia. In a child, less than 60 is hypoglycemia. If it is an infant, it is D10. In adult, we use D25, 25% dextrose. In a child, we use 10% dextrose. In an infant, you can give 2 ml per kg. In a child, you can give 5 ml per kg. Always recheck blood glucose after 5 minutes to ensure that the glucose has gone up. If not, you have to repeat the bolus, and also do not forget to start a maintenance fluid here. Because the patient is having seizure, you cannot ensure an oral feed. You have to go for a maintenance fluid. Every time you manage a hypoglycemia, you have to take a second action to prevent a hypoglycemia occurring subsequently. And in an emergency, you can even use, if the patient is having an asymptomatic hypoglycemia, you don't get a line, or you are not well versed in getting a line, you can simply put an NG tube and give the same dextrose through the NG tube also. But in seizure, always preferable to give IV, because if the seizure is hypoglycemic, the oral drug is going to take a longer time to act. And then first line AED, if the IV access, we always prefer injection lorazepam, 0.1 milligram per kilogram. Remember to give it very slowly, or injection diazepam, 0.3 mg per kg. Both these can cause respiratory depression. Depression with lorazepam is less than diazepam, but give it slowly. And if you don't have an IV access, you can always use intramuscular midazolam. The dose is 0.2 milligram per kilogram. If the patient is having a contraindication for IM, or you don't have an IM midazolam available, or the seizure is too violent, then you can, of course, use the perrectal diazepam or perrectal lorazepam. If you're using perrectal diazepam, it is 0.5 mg per kg. Perrectal lorazepam is 0.1 mg per kg. If your ED has a nasal midazolam, then nasal midazolam can also be used. It is for every 5 kgs, it is 1 puff each nostrils. So why I have written like this? Because the best drugs or the fastest acting is naturally the IV lorazepam. The second is IM midazolam, and the third would only be perrectal diazepam or nasal midazolam. How do you give perrectal diazepam? It is one of the simplest methods of administering a drug. Just take a feeding tube, make the patient lie on the side, insert 5 centimeters of the feeding tube into the anal orifice, and then give the required amount of the drug. Then pinch the buttocks so that the drug is not coming out, and remove. And once you have given the drug, do not forget to flush it with either a normal saline, and even an air flush is okay, because it is in the rectum. So it is less effective than IV, but this is one of the easiest method of giving an anti-seizure medication. So if we had done all these in the first child, probably the outcome would have been different. And also, whenever you have a child with a neurological problem, see that you are not having any life-threatening problem. See if the patient is having any meningeal irritation. If there is a meningeal irritation, we need to give the first dose of antibiotic because meningitis is a medical emergency. The antibiotic has to go within 1 hour of suspicion of meningitis. So if you're posted in a peripheral hospital and the place you are referring is going to take more than 1 hour, then you can definitely start the antibiotic, preferably after taking the cultures. If not, the patient can go to the tertiary hospital and there they can do the antibiotic as well as the CSF study. If you find any pupillary abnormality, any child whose seizure is lasting for more than half an hour, if you find an anisocoria, if you find a sluggishly reacting pupil, if you find a patient with a decerebrate or a decorticate posturing, all these indicate that possibly you're dealing with a raised ICP. If the BP is maintained, you can give mannitol 2.5 ml per kg. If you are not very sure about the BP, the extremities are feeling cold, then go ahead and give 3% saline. In trauma also, we prefer 3% saline over mannitol. So it is something that you can easily give. It is 5 ml per kg of 3% saline over 1 hour. So if you're suspecting a raised ICPs, the safer drug would be 3% saline. In trauma, always look for other injuries. If you're finding a bleeding pond, you need to tie a bandage so that the patient does not go for a hemorrhagic shock on the way. And if you're suspecting intoxication, again, antidote, if known, should be given, and activated charcoal can also be given. So every child with seizure, try to see whether you're seeing any of these signs which requires an immediate intervention or not. And finally, the last case. So this was a 4-year-old child who woke up in the middle of the night with complaints of abdominal pain and vomiting. And she had some breathing difficulty. SpO2 was 92%. So the patient was brought to the hospital and immediately the oxygen prongs were kept. And now the saturation improved to 94%. So now, are you happy with this child? You can have a look at the baby. What do you find? What do you think the child is having? Getting up, no fever, no cough, but got up in the middle of the night, had complaints of abdominal pain and then vomiting. And then mother says some form of breathing difficulty she felt. And so the child is brought to the hospital. So, and imagine if this is a situation that you're facing in a peripheral hospital, mark my word, this child will be brought dead to the tertiary hospital if you don't diagnose what is wrong with this child. Look carefully. What you see here is a child who is, in fact, what is the baby trying to do? Baby is trying to keep her eyes open by lifting her eyebrows. Why should a baby who commonly stands, for whatever reason, why should she go on trying to lift her eyebrows? If she's lifting her eyebrows, that means the child is having ptosis. She's trying to keep her eyes open, which she is unable to do. Look at her mouth. She's trying to verbalize something, but she's unable to verbalize. Unfortunately, you cannot see the chest properly. She's breathing, but she's not breathing enough. So what are you really looking at? You're basically looking at a child who has had a crate bite, and that is why you're not air entry is equal, no added sounds. And remember, if you're not getting any added sound, if you don't have a pathology inside the lung, why should the saturation be 92? The saturation to be 92, there has to be hypoxia. You have to get a wheeze there, you have to get a pneumonia there, you have to get something in the lung which can cause hypoxia. If a patient shows some form of breathing difficulty and has a hypoxia, look again. You may be dealing with a disordered control of breathing, or you're dealing with a child who is hypoventilating. So what will happen if you refer this child? If you refer this child with the oxygen, when you keep the oxygen, the saturation immediately improves because your lung is normal. Child is still breathing, even though she is breathing shallow, she's still breathing. So that increased FiO2 from the nasal prongs will bring up the saturation. But on the way, as the breathing becomes shallower and shallower, the carbon dioxide is going to go up, and suddenly the baby is going to go for a cardiac arrest. This is a situation we still see almost every year, and this is a completely preventable cause, and this you need to diagnose. It is okay if you do not pick up that this child has had a snake bite, but this is the classical symptom. In the night time, the child goes out to pass a urine, and child gets bitten by a snake, and the child does not realize it is a snake. And crate bite, mind you, it doesn't even cause much of a local reaction. Unless you search very carefully, you will not even see a bite mark. Local reactions are not seen, but this is a classical picture of abdominal pain and breathing difficulty. So even if you miss the diagnosis, it is okay, but you should be able to diagnose that this child is having a breathing problem. It is not an oxygenation problem. It is a breathing problem. So none of the oxygen delivery devices should be used. This child requires bag and mask. She requires support of breathing, not just giving oxygenation. So please start a bag and mask. And once you have got help, you can always intubate the child so that the airway is secured and refer the child. In case you are not able to intubate and if your hospital is nearby, then you can ambu and take the baby to the nearby hospital or go for a second help, because without an ambu, you cannot take this child. And if you cannot intubate, definitely please learn how to put a laryngeal mask airway. Laryngeal mask airway cost only 1,500 rupees. Different sizes are available. Even if you don't remember which size to be used for which age, when you take the LMA, it is written on top of it that which weight band needs that. So if you take a LMA size 1, it is written that it is for children less than 5 kg. If it is LMA 1.5, then it is for weight 5 to 10. So you can easily make out which LMA can be used for which weight band. So take the LMA, deflate it. After deflating, apply the lubricant on the posterior part and then position the patient as if you are going to intubate, and then introduce the LMA inside, pressing on to the hard palate. And once it goes in, it doesn't go in further. You know that you have reached the site. Then inflate it and you can simply connect the ambu bag and take the patient to the next place or to your hospital ICU or even to connect to the ventilator. So please remember, a patient who is not ventilating well, a patient who is not breathing well requires support of breathing, not just an oxygen support. So this is an important point that you need to look at. And there's only one take-home message for me. When you're working in the emergency, every minute counts. Use it wisely. Let's protect their smiles together. Thank you.
Thank you, Sheeja. Stop sharing. Okay. So for the house surgeons, I think this was actually a visual treat. But Sheeja has shown you all the scenarios, and this guide you can use in every day when you are taking a duty. She was talking with her own experiences and the cases which she has seen over these years. Over, Johnny.
Yeah, thank you, Sheeja ma'am, for that crisp and very lucid talk. In fact, we had a houseful Zoom today, and thanks for that wonderful lecture. And thank you once again, ma'am, for doing this talk at a very short notice at the first time when we had discussed it in the Pedicon venue. And if I would like to request house surgeons and medical officers, if you have any questions, either you can unmute yourself and ask directly to Sheeja ma'am, or you can put it in the chat box. Wonderful class, ma'am.
Thank you so much. It's my pleasure. Any doubts you can ask, anything you want to ask, you can ask, anywhere you were not clear, anything you want to know, or anything you have encountered in your daily practice, you would like to know, anything is okay. Doubts illa.
Can I add something?
Yes, sir. Yes, sir. Yes, sir. Vinoy. Yes, sir. Yes, sir.
The topic is recognition of a sick child.
Yes, sir.
And what I am going to say is not scientific, but it was what we were taught in our early period. The doctor makes an assessment and comes to a conclusion that the baby is not sick. But the mother says the baby is sick. Then we have to manage the baby as if the baby is sick, because we have to give importance to the mother. We should be very careful in reassuring the mother. That is what I remember. It was Elsie Philip madam told us. Thank you.
Thank you. Thank you, sir. I think that's a very valuable point, sir said. Please note everyone that, because many times, because mother is always seeing the baby. We are seeing the baby the first time. If the mother is anxious, never ever dispose that patient. Don't say that mother is simply creating a scene, because there's something in the mother's sixth sense. She is able to identify that something is wrong with the baby. So, sir, paranja pole, amma anxious anengil, please take that very seriously. Maybe we are missing something which mother has identified. I think there's one question, inotrope of choice and different types of shock. So basically, I didn't really touch upon that. If you have a cardiogenic shock, and if the BP is maintained, that is the child that we showed initially, right? There is a cardiomegaly. There is the BP is maintained, but the patient is distressed. In that situation, you can start dobutamine. Whereas in a cardiogenic shock where the BP has fallen, that is hypotensive cardiogenic shock, we prefer adrenaline. If the patient is in septic shock, you can use either adrenaline or noradrenaline. So noradrenaline is usually preferred for vasodilated septic shock. That means wide pulse pressure septic shock. And adrenaline is usually preferred in narrow pulse pressure septic shock. So in septic shock, what inotrope you start first does not really make a difference. If you're referring a child from a peripheral setup, always start an inotrope and set, so that on the way the patient is not arresting. Earlier, we used to use dopamine. Dopamine can still be used, but in the ICUs, we have stopped using dopamine, because dopamine is more arrhythmogenic and dopamine causes suppression of prolactin and TSH also. So it is immunosuppressive also. So we have stopped using dopamine. We use dobutamine, adrenaline, and noradrenaline. Okay, the next question is, if seizures are not getting controlled with first line, next which drug to start, especially in seizure disorder patient? So if you have given a lorazepam or diazepam, whichever drug you have given, and the patient continues to having seizure, wait for 5 minutes. You can repeat the same dose again. That means same drug. You've given Lora, you can repeat Lora. You've given Midas, you can repeat Midas. The benzodiazepine can be given twice. If in spite of 2 doses of benzodiazepine, if the seizure still continues, then your options are, you can either use a phenytoin or you can use a levetiracetam. There's nothing to choose between the two. Main difference is that phenytoin needs to be diluted in normal saline and it needs to be given over 20 minutes. Whereas levetiracetam can be diluted in both normal saline and D5, and it can be given more faster over 10 minutes. That's the main difference. And if you have fosphenytoin, phenytoin can never be given IM. Fosphenytoin can even be given IM. In severe croup, if we give IM steroid, won't the baby cry and the stridor be exacerbated? Is that why we should give it after NEP? Okay, that's a very interesting thought process, Nisha. But basically, it is not really that after, as you said, you can give after nebulization so that the immediate distress is coming down. Why it is written as IM is that if you're going to poke for an IV also, the patient is going to cry, right? And when you put something IV, you are going to keep that cannula and repeat the doses. So here you are planning to give only a single dose of steroid, parenteral. Parenteral is not mandatory. It can be oral also. But severe croup, you always want to give parenteral. So if you are comfortable putting an IV, that is okay. But since it needs a single dose, that is why IM is recommended. Dose of phosphene loading, if you're taking the whole of phosphene, then it is 30 mg per kg. That is phenytoin component is always 20 milligram per kilogram, but phosphene, it is 30 mg per kg in 20 ml NS, can be given over 10 minutes. NS or D5, you can dilute. At ER in periphery, guide on reliable telltale signs to distinguish between pulmonary and cardiac cause of respiratory failure. I think the most important sign between the two would be definitely looking for a hepatomegaly, because others and investigation X-ray only will give us a clue. So most common cause of respiratory distress is always pulmonary. Cardiac, we think when you find an unacceptable tachycardia, distant heart sounds, murmur plus minus with hepatomegaly, do think of cardiac. And another thing I would say is that when you have a child with myocarditis, one difference is that A child with pneumonia is usually more irritable with a lot of work. And myocarditis patients usually are very lethargic. And we say unusually cold child, think of cardiogenic shock. The extremities are very cold, think of cardiogenic shock. Extremely lethargic child, disproportionate to the degree of distress, think of cardiogenic shock. Basal crepitations, think of cardiogenic shock. Hepatomegaly, think of cardiogenic shock. Loading dose of levetiracetam is usually 60 milligram per kilogram. So it's easy to remember. It is phenytoin 20 mg per kg, your sodium valproate 40 mg per kg, and levetiracetam 60 mg per kg. I didn't say sodium valproate because it is not recommended in children less than 2 years of age, because there is a possibility you are dealing with a mitochondrial abnormality also. I think questions are over.
And one more question.
In unknown bite, how many times should we repeat clotting time to say no snake bite? Okay. So in an unknown bite, two things. We want to see whether it is a neurotoxic shock or bite or a hematotoxic bite. Neurotoxic bite in most cases appear early, usually within 6 hours itself. There are reports of, that is by 24 hours, we always say, there are reports of neurotoxic sign bites manifesting after 24 hours also, but most of the cases that I have seen, they manifest within 6 hours itself, most of them. And whereas hematotoxic bites may have a longer time to onset. So the recommendation is you check for the clotting time. Initially, you can check it for half an hourly or hourly for 3 times, and then 6th hourly. Usually, we would be monitoring for 24 to 48 hours. 48 hours is the usual recommended time. Okay, an epileptic child already on a drug coming in a status, does our protocol change? Okay, very good question. If the child is epileptic and has missed a dose, you can definitely give the same drug the patient was already on. Say the patient was on phenytoin, you can load phenytoin, but when we load, we don't prefer 20 mg per kg. In this scenario, we can give 10 mg per kg. But if the patient is already taking a drug, she has not defaulted and still has a seizure, the reason why she has a breakthrough seizure can be two. One is that the drug that you have given has not yet achieved the drug level. The second is that that particular drug is not useful for that particular seizure, for that particular patient. So what we commonly do is that in such scenario, we go for an alternative drug. The patient is already on phenytoin, we prefer levetiracetam. If already on levetiracetam, we prefer phenytoin or valproate. That's what we commonly do. But you can load half the dose also. 10 mg per kg may be given.
Dr. Nisha, if there are no more questions, can you bring that?
Thank you, ma'am. There is one more question.
Okay.
Any role for
budesonide? Yes, budesonide NEB may be given, especially in children with mild to moderate group who refuse to take steroids. That's very, very common. They don't take orally, they can be offered nebulization also. Mild to moderate, okay, severe, it's always parenteral. Nisha?
So thank you, ma'am, once again. Thank you all for joining. Thank you, team.
Good night.
Good night, all. Thank you.